our recorded webinar on Can We Hardwire Evidence into Digital Transformation? If we go to the next slide, please, I will tell you who we have here today. We're absolutely delighted to be hosting this. My name's Dr. Jean Ledger. I'm a Senior Research Fellow at the Department of Applied Health Research at UCL. I will be chairing this session with Professor Paul Wallace, who's Clinical Director for Digital at the Health Innovation Network, and he's Emeritus Professor for Primary Care at UCL. And our guest speaker today, and we're absolutely delighted, is to be joined by Peter Thomas. Peter Thomas is Chief Clinical Information Officer and Director of Digital Medicine at Moorfields Eye Hospital. So we will be running this webinar today for about 50 minutes. And just in terms of how the session will proceed, we have some questions to put to Peter for the first 30 minutes of the webinar. But we really encourage from the very beginning for you to place your questions in the chat. And around halfway through the webinar, I will hand over to Professor Paul Wallace, who will chair the questions that you've put forward for Peter, and we will have a discussion based on your questions around this topic of hardwiring evidence for digital health transformation. Please, you are free to keep your videos on or off as you like, and just keep an eye on the chat, because we will also be putting some articles today from Moorfields Eye Hospital and colleagues, which relates to the work they've been doing in digital health transformation, and you may find those materials really interesting. So we will crack on and get into the main topic and why hardwiring evidence generation for digital health is a webinar topic that really interests us. We're particularly interested in how evidence can inform service transformation and delivery in healthcare settings, but also the key obstacles and challenges of hardwiring evidence into digital transformation in real-world clinical settings. By hardwiring, we're using that term to think about how evidence can support implementation of digital health services and products, and making this a standard requirement so that stakeholders, patients and staff really understand how digital innovations work in practice, their costs, their effectiveness, their impact on services, and their patient and staff experience impacts. So that's how we're thinking about hardwiring evidence for digital health. I think to begin, Pete, it'd be really good to hand over to you and for you just to briefly, two things: introduce yourself, say a little bit about your role and background, and then could you tell us about whether you think hardwiring evidence for digital health transformation is a worthwhile goal, broadly speaking?
Yeah, sure. Thanks very much for inviting me. Yeah, delighted to be here. Clinically, I'm a consultant pediatric ophthalmologist at Moorfields, which means I spend sort of most of the clinical time with sort of lazy eyes and squint surgery and that type of thing. I've had a very long-running interest in technology. I actually started my career before medical school, spending a bit of time working for IBM, and then my research was around the field of computational neuroscience, and came into medicine fairly late. And throughout that, I sort of kept up a stream of getting interested in what's now called digital projects in healthcare, various things from, you know, researchy things, doing some sort of early clinical implementation of AI work, and through to things like medical workforce rostering with digital platforms. When I became a consultant at Moorfields, I was offered a role of clinical director of digital innovation, and that allowed me to start to professionalize a little bit around my involvement in digital stuff. So rather than being a hobbyist, actually to start getting involved in the day-to-day reality of getting technology into healthcare, and having that as part of my job and something I could focus on. Did that for a few years, and then became Chief Clinical Information Officer at Moorfields last year, around the time that we started a process of deploying an electronic medical records, and I spent an awful lot of my time looking at things around the deployment of EMRs and large bits of technology, as well as maintaining a bit of a focus on innovation. I do a fair amount of work nationally as well, so I'm the clinical lead on the National Eye Care Transformation Programme. I should be starting another secondment with NHS Digital on Monday, so I'll be splitting my time between NHS Digital and Moorfields. And again, a lot of that's around how we can use digital to enable service change. So rather than saying, right, we're going to implement this technology to get this result, rather thinking, Well, what do we need to do from an organizational perspective to change things so that we can make use of technology to implement different new sort of digitally enabled services? So I think that's the first bit by way of introducing myself. Second bit, question was around whether hardwiring this evidence is worthwhile and achievable. It's definitely worthwhile. It's definitely worthwhile. And what we've seen is a huge slew of activity over the past few years where different NHS trusts, different providers have implemented an enormous number of different technology solutions, but perhaps struggled sometimes to describe what the benefits of doing that was. So you don't necessarily always get the result you're thinking you're going to achieve. So you might roll out, let's say, AI supported voice dictation, but then find out that not many of your clinicians are actually that interested in dictating their letters, and actually they're using the sort of preformed macros from your electronic medical record. It's definitely worthwhile to do, and I think without it we can't really build those business cases and that sort of benefit realization framework to say this approach gave us the following clinical benefits, the following operational benefits, the following sustainability benefits, this environmental impact, unless we do hardwire that evidence generation in. As for the second part of whether it's achievable, I think it is achievable, but I don't think it's achievable without some level of organizational change. So we've known for a number of years that we haven't really got it right in terms of how we do technology in healthcare, and that was the subject of the WACTA review back in 2016 after the national sort of that almost post-mortem to the National Programme for IT, and a lot of that spoke about the role of the clinicians and professionalisation of clinical informatics, and we find it's an incredibly varied picture across different NHS trusts. Some are, very advanced in professionalising their clinicians to support really good digitisation. Others aren't. At Moorfields, we identified a need for a little bit of a different approach to how things had happened historically. So we created in the early parts of last year this new thing called the Department of Digital Medicine, which we could equally have called a Department of Clinical Informatics. It's just that not many people know that well what clinical informatics is, but digital medicine's a bit more sort of obviously explainable. And the reason for doing that was we felt that in order to get much better at having clinicians supporting, sometimes leading on that digital transformation process, we needed to create this sort of central nexus where they could go for support, where they could spend time with each other, and where we could really formalize the links between that group of people and the other stakeholders in the hospital, like information governance, like IT, like research and development. And as part of that, we've got much better about tracking which projects we're doing and trying to get a sort of program management approach to all of these different innovation projects that happen in any sort of academically leaning NHS organization. And we've been able then to make sure that all of those projects have got an evidence generation arm to them. So whenever we do an implementation, we're then trying where possible to link it up to one of our digital fellows. We've got quite a few digital fellows at the moment, from DARSI programs, from TOPOL programs, and in-house ones as well. So, they're all very interested in the evidence generation side of things. So we're trying to pair up these programs with people who can support by getting the quality evidence out of it and then publishing it. And also making sure that we cover all of our bases so that we're not just doing the evidence that people find interesting, because you'll often find this, that someone, if you're doing it in a silo, if your organization doesn't support you as a clinician to do digital transformation, you'll implement something that meets your needs and then you'll publish the research that you find interesting. But by doing this sort of more structured approach, we can make sure that we generate the research that's useful for planning and sustaining those services. So what is the environmental footprint of it? What's the time saving for a patient, doing the time and motion study? Some things that may not naturally fall middle of the bat for interest for a lot of people running these services, but it's that kind of evidence that makes a service sustainable. So achievable, but I needs a bit of thought into how you're going to achieve it.
Can I just pick up on something, because this Department for Digital Medicine, it started last year. I think before we get into the programs that sit within it would just be really helpful to understand where that's sat within the wider trust strategy and who supported that department getting set up, because there may be other organizations thinking of doing something similar or trying to bring together their digital innovations with, as a strategy across the wider piece. What did it take to get to that point where you could have this group of people doing these programs? What do you need?
So I think a lot of the raw material pre-existed it. So we had a chief clinical information officer, we had a couple of clinicians with dedicated time, we had some digital program management that was happening in other parts of the organization, like the service improvement. We had something called a reading center led by a colleague of mine called Consultations, who does absolutely amazing work with implementation science and AI. We had these, but they weren't all very well connected. So we had a lot of the raw materials. It wasn't something we had to go to the organization and say, right, I need loads of money in order to do this. Rather, it was about setting out a vision, justifying why clinical informatics is this thing that links together lots of different bits of work that may seem unrelated, and then setting out a vision for how structuring it, centralizing it, and sort of professionalizing it would help it to run better. We had tremendous support from our chief executive at the time to do this, and it linked in with some sort of national priorities. So our chief executive then was also leading the national rollout of video consultations, so he was particularly attuned to the issues other organizations were having with some of this digital transformation work. So it required us to, I'd say there's probably three things. It required that very senior support to get it done. It required us to have a good understanding of what was currently done and how to bring it together. And it also required us not to go in asking for huge amounts of money, because I think in most organizations, this concept of clinical informatics probably isn't well enough embedded to go in with these massive business cases. We need to be almost justifying our existence and sort of leading the organization along that journey that was set out by the Topol report, by the Wachter report. So that's still a process that's ongoing in many NHS trusts.
And interestingly, in terms of context, you described it as Moorfields as an academic-leaning organisation, and it's got a precedence of engaging with universities and publishing research. So the evidence piece is part of the organisation anyway.
Absolutely, yeah. We're historically really good at some of the at that more basic level of research. Really sort of deep level. How does the eye see? How can we take a different approach to treating things? On the digital side, a lot of the research we did was really sort of really impressive, innovative stuff around AI. But there was a little bit of a gap to applying those research methodologies to the more sort of day-to-day side of digital things. And so an important part of it was saying that this is a useful and interesting target for research. So now when we do home vision monitoring, for example, we're coupling that together with qualitative research to understand why patients engage with it. So it was a matter of bringing together pre-existing capabilities with pre-existing needs and saying, right, how can we be really corporate in our approach to that and target the right bits of evidence to generate?
Well, music to my ears as an implementation social scientist in digital health, so that's really exciting. I think our colleagues are going to put some of the papers in the chat that you've produced as an organisation, and it'd be really interesting now to think of that wider piece and these projects and programs that you've got running. Could you tell us a bit about what you've been doing around teleophthalmology? I know that's been a big thing. You've been using Attend Anywhere software for video consultations, and have even done this in emergency care. So could you tell us about some of these digital innovations that you've been embedding, and then we'll talk about how you've been evidencing them?
Yes, I mean, the video consultations is a really interesting one because it's not that exciting for many specialties. It's a sort of well-established model, particularly in areas like mental health. In ophthalmology, it was a situation where video consults just weren't a thing. And by and large, COVID started, you'd say to people, well, let's start doing some video consultations. And I say, well, there's just no role for them in ophthalmology because we are so used to examining the eye. When you get an ophthalmology patient in front of you in clinic, we put them on something called a slit lamp, which is basically a microscope. And we can see down to microscopic detail inside the eye when we examine it. So if your patient stays nice and still, you can see individual blood vessels floating around in the front of the eye. So if there's inflammation, you can count the white blood cells floating in the eye. You can see, the flow of red blood cells through the conjunctival network. And we've got these, incredible devices that let you, OCT machines that let you get down to sort of, tens of microns of level detail of a cross-sectional scan through the back of the eye. So then you say, right, get rid of all of that and switch to a video consultation. That's culturally quite a difficult thing to do. In order to do it, we had to identify those places where it was going to be useful. And one thing that came out of that was on the emergency side. So in the early days of COVID, we wanted to do two things, really. We were really worried that patients would have early symptoms of blinding disease, particularly retinal detachments, where on day one you got a few floaters, but maybe 1 week later, the eye's completely lost vision. So we want to make sure those patients had a way of flagging up their concerns early without being worried about exposing themselves to COVID by a trip in. Conversely, we wanted to make sure that those patients who were thinking, do I need to come in? If their symptoms weren't consistent with that, they could find a way to find out they didn't need to come in. So we set up with those real two expectations, this video service, and within about a month, it was the largest video consultation service on that national video consult platform, seeing, I think at one point twice the number of patients as our physical A&E was. And we coupled that straight away with the evidence generation. So because it was such a new thing in ophthalmology, because most people said these don't have a role, we were very conscious that we could find ourselves under a great deal of scrutiny unless we had that evidence to justify what we were doing. So within the first month, we'd measured the number of appointments we were avoiding, and we reckoned it was about 78% of patients who presented as an emergency, we could avoid them making a visit on the day. And about half of patients in total never needed to go to a physical site. And that 28% difference, those were patients who we could route straight through to a specialist clinic first time, reducing the number of visits, or we could send them to somewhere more local. We also needed to follow it up with safety evidence. So within that first month, we gathered consecutive data for 900 patients, half of them passing through physical A&E and half of them through video consultation, and then searching through everything we had available a couple of months down the line to find out, was there any potential or actual harm generated from that? And we were able to prove that way that when people say, well, it's not safe, I can say, well, actually, we do have this very large audit that we published in Lancet's eClinical Medicine journal to say this supports it in being safe. We also did a large amount of work to find out whether it was desired by patients, because again, when I was doing my sort of unofficial role of trying to get other ophthalmologists in other trusts to use this, something that frequently came back was, well, patients don't want it, or we don't want it. We were able to show by gathering information after each video consult around whether it was useful, whether patients liked it. We were able to show that actually, yes, patients preferred this in many cases to face-to-face, although, you know, obviously during COVID, they might prefer it because they don't get exposed to COVID. They preferred it to telephone. We were able to show that it was a valued service, and also to show how muw time it saved patients. So we've been able to evidence that you know, the carbon saved by patients not traveling in. We're able to show feedback from patients, qualitative feedback from patients saying, well, these patients said that they were able to attend because they didn't have to take time off work, and under normal circumstances they may have struggled to attend it. So with the video consultation in general, we coupled it with all these different bits of evidence generations to try and cover all our bases. So when you talk about these benefits realizations frameworks and you think clinical safety, efficiency, all these different things, we try to hit all those. So video consults was an interesting one, and as a result, we've been able to sustain that emergency service where many other video consult services from secondary care have sort of folded, and that one service alone, I think, is knocking on towards 50,000 patients seen and managed over the past couple of years, which is a pretty significant service from something that was completely not described before. We've taken a similar approach, I suppose, to other services we've offered, and I think remote monitoring is a good one for us. So we're not that interested in blood pressures and stuff like that in remote monitoring, but we are very interested in how patients are seeing. So we had a few different bits of work, some of which was generating new remote tests of vision, which we did coupled together very strongly with the research and development. So we published a quite nice thing called the home Acuity test, which is a printable test of vision. And we posted that out to lots of people as well during the first COVID lockdown, so that during their video consult, they had something to test their vision on. So in some cases, it was on the research side to validate this as an approach. On others where we had CE marked approaches, and we got about 500 patients still signed up to test their vision using apps on their mobile phone. There, we're very much focusing the research on how many patients does that allow us to intervene earlier on. So if their macular degeneration's going off, how well can we use these home vision monitors to red flag those patients and get them in early? So we've published some research to show how often we're picking up these red flags and the difference it's making to these patients. But we're also conscious that we've got major issues with scaling this in terms of patient engagement. And, you know, we hit that 40 to 50% barrier of patients who want to do this or are able to do this, and it's hard to break through it. And once you sign them up to these platforms, it's hard to keep them going. So in JAMA Ophthalmology, we published a nice study led by my colleague Konstantinos Velasquez, that was looking at those qualitative factors around sort of qualitative research study, which is identifying those factors that either enable or disable a patient from doing this. And on all of it as well, we've also started looking at what the digital exclusion side of things, because that's probably slightly underserved in research. One of my colleagues, Amrit Sami, who's our Darzi Fellow, focuses entirely on this. And I think we're going to see a nice output of evidence for how we can tailor these services to minimize that digital exclusion. So we try to take a similar approach to all of the services.
I mean, there's so much going on. It's fascinating, but I want to ask the question, because a lot of the work we've been doing on thinking about evidence standards for digital health evaluation frameworks is a very complex landscape when it comes to producing the evidence, and you need the resources. But there's that interesting relationship between traditional research and healthcare evaluations and real world evidence generation and audit. And what's really striking about what you've done during COVID, given pressures on the service, I mean, even it sounds like you had increased demand when people started using the video service, is how you still managed to do the evidence generation bit. And I just wondered if you could maybe talk us through maybe the example of video or remote monitoring, how when you're getting to that point of implementing, you've got systems in place to capture that data and to be looking at that data in a continuous way. So if something's not working, you can adapt, you can stop. When we innovate, we also need to know when to stop and not do things, or when, as you said, you're actually getting better feedback perhaps than you expected, more usage and demand. You're still generating the evidence, but it's a different form of evidence. It's not independent evaluators coming in 6 months later, you're doing it in real time. So could you tell us more about that? What do you need from the moment you hit the ground running with implementing these? What needs to be in place?
So I think what we try to do is when we're starting a new sort of project or program of work, it is always thinking, what are the useful publications that might come out of this? I mean, we're really spoiled, I suppose, at Moorfields in that, we've got a fantastic research arm with the Institute of Ophthalmology, obviously UCL organisation that we sort of tightly partnered with. We've got an NIHR Biomedical Research Centre. So we've got lots of people who are involved in research. And we've got absolutely fantastic trainees in ophthalmology, lots of very academically oriented allied health professionals who are used to churning out research. And for them, for us, we're a little bit lucky in that it's kind of natural for people who are involved in this to be thinking, right, how am I going to evidence what I've done here for my next appraisal, which is nice, or how am I going to do it to get a publication out and enhance my CV for a consultant post? Obviously, a lot of these things are, sort of career oriented as well. So we're lucky in that what we tend to have is a lot of the clinicians, particularly who are involved in these programs, automatically think of research. When we have our sort of kickoff sessions for new projects, what's publishable typically comes into it. If we look at our digital medicine fellows in particular, so I think we've had 5 or 6 TOPOL fellows through the organisation now. We've had one Darzi fellow in at the moment, another one coming in next year, and we've had 3 locally appointed digital medicine fellows this year. What we tend to do with those is most, particularly the internally appointed ones, tend to have a project which they're involved in as a sort of leadership position. They've got their own project that's got their name on it. But we've also tended to attach them to a more researchy project as well. So for example, one of our past TOPOL fellows led a lot of our work around bring your own device imaging, so getting clinicians to take photographs on their own phone in an information governance approved way, but also getting involved in some of the AI work around, let's say, implementing an AI algorithm to monitor the progress of something called geographic atrophy in AMD. So we tend to try and split them between those sort of more researchy oriented projects and more implementation projects. So, in doing so, we kind of create an environment where the evidence sort of generation tends to happen almost naturally. Sometimes it is really important to, from the person who's leading this, whether that's myself or a colleague, to make sure if we're implementing something and we know there is going to be a particular type of evidence we need to produce in order to continue it. So for example, with video consults, it was very much around patient safety. We knew that people were going to get bashed for patient safety in video consultations. We've seen criticism in a lot of the press for other video consultation services. So we knew from a more corporate side, that we definitely had to cover that base. So with that one, that was something that we consciously made sure that someone was definitely going to do it, almost fingering people, saying, right, typically our approach for clinicians doing research is to do what you're interested in, but in this case, this really is something you have to publish, and luckily everyone's fairly aligned on that.
So, I mean, I think that's what's really interesting. It's that you can have the curiosity-driven research, but actually it's the corporate needs and the service needs and the safety needs for evidence generation that actually led a lot of the activity, which is really interesting. And what about the challenges? I mean, there'll be other organisations thinking about doing this. What do you see as the biggest challenges to hardwiring this evidence generation into your service delivery, into your digital health transformation at an organisational level?
So I think having the resources to do it is a really big challenge. So we're lucky in that we have quite a lot of people who do digital stuff on the research side. I've got a reasonable amount of my time dedicated to being a chief clinical information officer. We've got a fair few other people who have sessions here or there to get involved in digital work. And we've got lots and lots of fellows, which means that, and lots of interested trainees and allied health professionals and other types of clinicians who want to produce research. So for us doing the evidence generation, we've kind of got the natural resources there and we've got the mindset to do it. If you look at a lot of other NHS organisations, and there are some that are better than us at doing this and others that aren't quite so good. I did, as part of my Digital Academy sort of MSc research, I did a sort of qualitative research study where I engaged with 40 other digital leaders in central NHS organisations and other NHS trusts. And what came back from that was just wildly varying amounts of resources. One respondent saying that it was almost like the 1980s where they were, a CCIO and nobody quite knew what to do with them and there was no support and no team. And a lot of places really hugely underfunded with clinicians very little funded time or able to get involved in digital. So I think that resourcing, so it's often going to be clinical informaticians, I think, who do a lot of this evidence generation or set up the framework for evidence generation. So if you don't have this well-established concept of clinical informatics or a CXIO team or something like a Department of Digital Medicine, you'll struggle there. And partly some of that comes from the top as well. So we've seen, I think Health Tech News did a survey for digital representation on NHS boards, and I think there was only 2 CCIOs who were on NHS boards as a result of that, and it was less than half of boards had anybody who was primarily digital on the board there. And so I think we find that across quite a lot of organisations that understanding of what's required for digital transformation, which involves the evidence generation, isn't presented at a high enough level, and that concept of clinical informatics isn't presented or represented at a high enough level in order to help those senior leaders understand why they should be focusing on this, why they should be creating time in people's job plans to do something that isn't obviously as useful as seeing patients, but pays off in the long run. I think also, a big driver for the evidence generation is always going to be patient safety as well. And I think we're at a slightly awkward place at the moment with patient safety in digital health. So there's been the concept of digital clinical safety reporting for...
the music competition, Papa.
Sorry about that.
That's all right. For probably over about 10 years now, but a lot of trusts haven't well established the idea of their clinical safety officers and their digital clinical safety reporting processes, and so digital clinical safety around digital things can float a little bit free among the sort of standard clinical governance processes that don't quite know what to do with it. So embedding specific processes of digital clinical safety also serves as something that I think can sort of force you to generate evidence, whereas previously you may have just sort of trundled along without it. So yeah, it's professionalization, it's resourcing, and it's setting up a structure around this stuff that I think are the biggest challenges. And often we tend to find there's little professionalization, there's little structure, and there's little resourcing for clinical informatics in too many trusts still, although my own and some others are doing a really good job on that.
And there's obviously, it's a strategic priority for the organisation. You've already had things in place, but it's also just, you mentioned some organisations, it's, for example, started with video and they may have stopped. And what seems really important in terms of the evidence and audit story here is that you can sustain the digital transformation and the change if you've been documenting its impact as you go. Whereas if you've trialed something, done a pilot, it hasn't been documented, it might not be a sustained change. And it seems that for sustaining the transformation and the service improvement piece, it absolutely has to be hardwired into what the organization is doing and how it's thinking. Is that something you'd agree with? Or
yeah, absolutely. So and I think the interesting thing is sort of telling the story of why you need to generate different types of evidence in different scenarios. So I think, we've got an awful lot of organizations that are terribly excited about implementing clinical AI. And one of the interesting things around that study I did was that it was on a Likert scale where 1 was strongly disagree and 5 was strongly agree. And the question was, is your organization ready to implement things like clinical AI? And out of the 40, there was only 1 person who said strongly agree, and everybody else was neither agree nor disagree or below. So that's a bit of a problem, because everyone's terribly excited about these new technologies, but the people who'll be involved in implementing are saying, well, the organization's just not ready for it. And part of that's about setting up the structure, but part of that's giving a clear message. So why do we do remote vision monitoring at the moment? So we can't save loads of money by doing remote vision monitoring. I couldn't make a business case based on efficiency savings, because as yet that isn't as accepted a method for reducing the number of follow-ups. So we can't space these appointments out further to reduce costs. But in order to get to a point where we can space follow-ups out further, we need to implement it and start generating evidence to how it works and what it does and who engages, and works out how we can increase engagement and work out what to do with patients who are red flagged, in order in 5 years' time to get to a point where we could start generating those cost savings. So I think it's also important when you're sort of hardwiring this stuff in to make sure you're clear on what's the purpose of doing a given project. It may not be that we immediately want to scale up remote vision monitoring to 50,000 macular degeneration patients. We might be perfectly happy to sort of trundle along with a few hundred while we're working this out, because only by doing that and generating the evidence can we get to a point where it becomes scalable. We're sort of not making it up as you go along, but you're building that train track as you go along with it.
And step at a time. And I just also wanted to ask, before handing over to Paul, has there been anything in the evidence that you generated that's really surprised you? You touched on a couple of things, but where you've got patient or staff feedback, or from even operational and real world data coming in, that you've gone, that really wasn't what we were expecting. Maybe there's some examples.
Yeah, so I think it's back to the video consults were probably the surprising thing. So I had in no way expected that we'd find such a big niche for them in the management of acute eye presentations. That would I think for a long time that was the largest waiting room on the national video consult platform, was the Moorfields accident emergency. I really didn't expect it to be that successful. I don't think anyone expected it to be quite as successful as it was. What I also didn't expect as well, and it comes into the sort of digital exclusion and inclusion thing, was that digital exclusion is a definite problem, and we know this is something we need to tackle, and we've got active work to do this. But the digital inclusion thing was something I hadn't really anticipated, and very often we do get challenged about, if you're going hell for leather to do all this digitization, what about the excluded patients? And absolutely, definitely, there needs to be alternatives in place for them. There needs to be an add-on, but we are actually including quite a lot of patients we previously excluded. So I did an interview on Radio 4's In Touch programme with one of our patients who used to travel down from Essex, and she was able to replace some of her visits with video consultations, and was saying, well, for her it was a full day, it was a 50 quid train return trip. From these sort of qualitative surveys that we've generated some publications from that come up after our video consults, we're getting evidence about people who were able to attend their appointment because it was by video, so they could do it from their car waiting for their kid outside school, whereas previously they'd have struggled to attend. Or even they're unable to take time off work because they're self-employed and they can't cope with the income loss, but by doing it on video they can just nip outside, do the video somewhere private, nip outside, do the video consult and go back in. So I think that's been the most surprising one, that the role was different to what I expected it would have been in advance, and some of the benefits we're seeing were not benefits that I had anticipated in advance either. I think we find similar things across a whole range of different programs around remote monitoring as well, and around some of the other work we're doing.
And very quickly, I think the waiting times and access, was there anything in particular that came out on the data, as well as convenience for patients? It looked like from one of the paper I saw that waiting times were really quite short.
Yeah. So I mean, I guess it fluctuates by staffing level, but when we measured early on, when we measured what the overall waiting times were for video consults from the emergency service, it was something like 9 minutes between clicking on your link to join a Moorfields video consult in the accident emergency. That's without a referral, without a book slot, to actually then talking to an ophthalmologist. I'm not aware that exists anywhere in the world, that you can get straight through to a trained ophthalmologist. There aren't many trained ophthalmologists. It's a high volume specialty with not many specialists. I'm not aware there's anywhere else in the world that you can get through so rapidly there. And that worked very nicely. I mean, a lot of the sort of early success of that was driven by, it was a really good way to make use of staff who were shielding. So these people were desperate to be contributing, but for various reasons had to shield at home. And it just led to the perfect environment to set up a service. And if I'm honest, I don't think there's any way we could have set that service up without COVID. And I think if we're starting from scratch now, we'd struggle to set it up. But because we could get our foot in the door, because we could develop all the evidence to say the good it was doing, the benefits it had across all these different domains, is something that now it's in, we can sustain. So, not looking a gift horse in the mouth is an important thing for that.
I mean, it's just amazing work to hear about. And I think you've really answered our question for this webinar, which was about making evidence generation routine with digital health transformation and implementation. I'm going to thank you very much and hand over to Paul, Professor Paul Wallace, who may have some additional questions and has been keeping an eye on the chat. I haven't. I don't know if there's any questions that have come in from the audience, but Paul, over to you.
Well, thanks very much. Thanks, Jean. Thanks, Pete. Absolutely fascinating. And I think sort of overwhelmingly impressive. I think all of us listening to what you've managed to achieve at Moorfields are thinking, wow, if everybody could do that, that would be really wonderful. I've had a look in the chat, and so far we have, I was going to say, a well-behaved audience. I want you to be ill-behaved and put lots of questions and comments in there. So I'll start off with some questions and see if others do. But please, if you've got comments or questions, do put them in the chat and we will read them out on your behalf. Starting with just thinking about how translatable this is. If you were to be talking to your equivalent, or maybe a CEO in a small secondary care trust, what would you say to them about trying to do this? They don't have the kinds of resources that you have. They don't have the academic input necessarily, or the fellows. What would be your advice? Because I think quite a lot of people on the call might be thinking, how could I do something like this?
So I think the important thing is to sort of, and I try not to be sort of too sort of cultish about it. It requires a process of helping people to understand, what clinical informatics is and why it's important, because that's generally going to be the capability that helps clinicians to get involved in implementation and helps to create that sort of evidence generation framework for these things. So it requires a lot of engagement with sort of more senior leadership in the trust to say, well, you've got a CCIO, but how do we turn that CCIO from someone who sort of rubber stamps things that the IT department are leading on, floats between different projects, doesn't really have a proper structure under them to help them get things done, to sort of saying, well, if you did have that structure to help you get things done, these are the kind of things you could be doing, and here's examples of how that's happening across the system. We see, just in London, other great examples of places that have done this even better than Moorfields have. So I think that there is a big thing of sort of engaging with senior leadership to try and develop the case for getting a lot more professional and a lot more resourced about clinical informatics. I think obviously we're a bit spoiled in terms of the sort of the quality of research collaborators we can call on, and almost every sort of clinician in the place has got a great big long publication list of papers they've been working on. And obviously, it's nice to have that string to the bow, but a lot of the evidence generation doesn't have to be that type that's sort of really in depth, this molecule does this and therefore that. Some of the stuff we've published has been, useful audit publications. There's no great science in there. There's just, it's just, we did this and this is how we measured the outcome and that's what happened. We published blueprints. And a lot of those things, so there's types of evidence you can generate without needing to have access to really sort of, top-level statisticians or sort of really academic collaborators. So I think it's possible to set up those academic, those sort of evidence generation frameworks without getting too obsessed about what the academic aspects are.
Yeah.
And there are now more journals that will accept papers, which there weren't 5 years ago. I can now publish about how you implement video consults, and I can stick it in the BMJ Health and Care Informatics Journal.
Yeah.
And there weren't many of those a while back. It was just not on the radar.
Well, without wanting to plug them in any way, BMJ Innovations is actually part of the support structure for this webinar series. So I think it's a very important point. I mean, clearly what you're saying, and I've got an eye on the chat still, clearly what I think you're saying is it's a leadership issue. It's about people realizing, and I think you were saying it's both about the value of digital transformation itself, but also the value of evidence generation. Clearly, some are going to be leaders like yourselves, and some are going to take much longer, the diffusion of innovation. But what do you think could be done nationally? Is there something that you recognize is missing nationally? After all, usually if there's a requirement to do something, we all jump. We don't necessarily jump in a meaningful way, but we jump. What do you think could be done that would be helpful, that would encourage either, regulation, funding, training, I don't know, education?
I think all of those, there's stuff that could be done nationally. On the funding side, I think it doesn't, most of the funding that's available for research and things like that don't obviously fit very easily with evidence generation from digital transformation programs, because the methodology might be really iterative. You may not be able to write down exactly what you're going to be doing 2 years ahead of time, which is going to make it challenging to apply to those sort of more traditional funding sources. So I think funding is definitely an issue. Training's a huge issue, and for most of my career, my sort of interest in technology and we're now called digital sort of sat uneasily alongside me being a clinician. It was something that I did during my admin sessions, or sessions I was meant to be spending revising for exams and stuff like that. I'd be making sort of ad hoc collaborations with the computer science department, or I'd find something that was interesting to me and I'd sort of push it through. It's now improving. So I mean, we've got TOEFL fellowships, a lot of the Darcy fellowships are sort of, seem to have a little bit of a digital angle as well. We've got the NHS Digital Academy, but as yet there's no backbone that connects all of those things. So we still have there are opportunities now for clinicians during their training to get involved in digital and bring the mindset that we'll want to generate the kind of evidence we need to sustain it, because I do think it's critical for clinicians to be doing that. Often you find when you're approached by a company that's got a really great product, they'll show you your evidence and you think, okay, great, but that evidence isn't really anything that's going to help me implement it or justify why I'd want it. I know that your AI algorithm can do this task, but maybe isn't a task I need to do, or it's not a bottleneck in the process. So I think clinicians being involved in it are really vital, and those being involved in sort of real world of healthcare. So I think we're quite disconnected between the different offerings at the moment. So we've just had our first former TOEFL fellow get accepted onto the NHS Digital Academy this year, which is absolutely great. So we're seeing people progressing from those national offerings. But I think there's a lot of work that could be done to connect things up, so that there's a certain amount of informatics at medical school. There's options that you can do alongside your foundation training, maybe even a secondment or a placement in it. There's then the fellowships, and then maybe there's a framework within each specialty training to get people going with informatics, so that there's actually a clear process that leads to these CCIO positions.
So some sort of national initiative that actually promotes that sort of linkage at all those levels. Yeah, we've got a question from Alice Cotton. Alice, would you like to actually give the question yourself? Do you want to unmute and give the question yourself?
Hi, sure. So I am looking to do a project at Guys and Thomas's to try and tackle digital inequalities within cancer care. I know you mentioned this briefly already, but I just wondered if you had any success stories about addressing some of these inequalities, and any tips or advice for me. That would be really helpful. Thank you.
Yeah, thanks. I think we've got some success. I think there's loads more work we need to do. I think some of it is around making these things as accessible as possible. So I think the video consult thing worked well because it was drop-in. You went to the website, you clicked on a link, we had clear instructions, and then you were straight in talking. There wasn't some process where you had to go to place A and get a referral. So I think making the services really accessible. I think there's also I think people had a tendency to think that once we can move to different forms of telemedicine supported by digital solutions, that all of a sudden there'd just be efficiency savings all over the place, and we could say, right, we need fewer clinicians because it's all asynchronous now. But what we find is that there actually needs to be quite a big support offering placed around a lot of these different things. So particularly with the home vision monitoring work, that needed to be backed up by, in this case, a project manager who could really directly engage with the patients, a phone line. So the patients had somewhere to call when there was a problem. We needed to provide them with training on it, sit with them in clinic and take them through it. So I think we're beginning to bottom out a little bit about the support structure that's going to be need to be placed around these. And I think it's, you're bound to fail and bound to have lots of excluded patients if you just sort of chuck out a digital solution and say, get on with it. Actually, when you're planning for that service, you need to say, right, well, here's all the bits that are not going to need to go around it in order to support a patient to use it. And I think we've got a lot of distance to go in getting better on that. Around the digital exclusion specifically, we're doing a fair bit of work to work out, the best ways to provide alternatives. So one of my colleagues who I mentioned earlier, one of our Darcy fellows, is doing a lot of work around digital exclusion and been saying, right, well, we've got these video services, but what if you don't have video? So we've got a little sort of traveling video pod that's going around a few of our sites now where patients can go along to in order to do a video consultation, and coupling that together with a bit of training. So, they can have their video consultation in a site on the Moorfields network that allows them to connect up to a clinician somewhere else in the network. But at the same time, that's an opportunity to train them. That's an opportunity to sort of show them, like, this is how you would access it from home on your phone or a tablet or a computer. And I think that's going to end up being a fairly successful strand of work. Because really what it's doing is looking at what the approaches are to minimizing digital exclusion. I think there's a slight tendency for us to say, right, we shouldn't do it because of digital exclusion, but actually thinking, right, well, let's get going. Let's make sure there's alternatives. And then alongside, let's start generating evidence about methodologies to reduce that digital exclusion or reduce those inequalities. So in that case, doing it via video pod. And, you'd hope a year from now we'll know whether us providing little private rooms on site for people to do video consults and a bit of training, if that leads to a sort of sustained benefit for the patient, or if we need to try something else. So I suppose it comes back to this theme of evidence generation, that we need to start backing up what we say about digital exclusion with evidence that it really is excluding people, and also with evidence that methods that we come up with to reduce exclusion is actually working. Some success, but early days.
Pete, let me just, thanks very much indeed, Alice, for that question. Let me just follow that up a little bit, because one of the things that we're all aware of, I think, is that if you're going to do digital transformation, it needs investment. That was really what you said. And if you don't invest appropriately, you're actually much more likely to fail than if you, so there's a hump. In the end, you can get over that hump. And if you're successful, then it becomes implemented, it becomes embedded, and you reap the benefits. Who are the key players, stakeholders, that you think you need to report your evidence to in order to persuade them that the hump is worthwhile?
Yeah, I think I'm probably still in the process of finding that out. Pretty much everybody is how it seems. I mean, it's definitely something that we need to get better on, anywhere, and including at Moorfields as well. Is that there are so many. The problem is, I think maybe in the past viewed technology as its own thing, and therefore there are stakeholders who get involved with it. But actually, as soon as you move a service onto a digital platform, it starts having stakeholders all over the place, exactly the same as a clinical service not digitally delivered. So it's not just the usual suspects of IT and IG. Suddenly, you're into the clinical safety committees, you're into your clinical governance committees. You need to engage with the research people to explain to them why something you're doing is new but not research. You need to then start making your arguments to sort of your operational leaders that this is something that leads to something beneficial. Need to get support from right up the chief executive. So I think the answer is pretty much everybody, unfortunately. Certainly that senior leadership team absolutely need to be on board, but you know, we're conscious. We set up this Department of Digital Medicine, you know, going back to the start, it was, you know, a small undertaking that's now growing. There's always the question, are we engaging fast enough and well enough with the rest of the organization? As we grow, we're getting better at it, but really conscious that if we want to stop a little bit of siloed activity over here, that would go much better if it linked up with us, that we need to make sure that everyone knows about us, everyone knows the way in, we're building those ways in. So I think it's a whole organization thing.
So there's something about reaching out across effectively. And what is, if you're dangling carrots in front of them, and we all need incentives, I think you talked about it before, you know, publications may be one of the things, but what are the key carrots? What are the key incentives if you look that you can try to ensure that you're focusing on, so that people can reasonably pick this up and say, yeah, actually, I can see why that works.
I think to get the people involved in setting these things up and doing all the work around it, including generating the evidence, the key is to say, well, this is part of your job. This ain't just a hobby. It's not just something you can do on the side of it. You need to have funded time. Now, we're getting better with our funded time, and particularly at the sort of fellow level. We've got lots of fellow support, and they're producing really fantastic work, so that's really important. But we don't have much funded time from our allied health professionals to get involved with this at the moment. We've got a few consultants with it. We're a little bit medic heavy in terms of the funded positions. So I think to get people going with this, you need to say, well, we're going to regard this like we do a research session or like we do an admin session or something. You know, we acknowledge that you need to spend a certain amount of time doing this, and it will be in your job plan. I think that's the most important thing, because all the other carrots are kind of nice to have, but the carrots are the first things you stop worrying about when there's a major crisis to deal with. So it really needs to be part of people's jobs plan. We've been getting away with this for ages, you know, exploiting people's enthusiasm, exploiting, you know, people will be working into the evenings writing these papers. We've got to move away from that and saying, you know, this is time in your job plan for digital stuff. The organization recognizes that this is important and is putting money in to do it. And I think that's the way that you make it sustainable, because otherwise you end up with the whole thing collapsing as soon as a few of those excited, enthusiastic people move on. It needs to be.
It rings very true. I mean, I think the NIHR, the National Institute for Health and Social Care, was Health and Care, actually is built on the same thing. It's about hardwiring research into something that, you know, everything that you do, it's part of the NHS constitution. So maybe we need to make sure that that happens too. We're getting very close to the end of our session, and Jean, I'm going to hand back to you for, I think, a question and then the closing comments.
So one final question. We have a project between King's College London, University College London, with a number of partners supporting, like DigitalHealth.London. And we've been talking to digital health companies about their own evidence that they generate, and just often how difficult it is for some of these startups and digital health companies, because they don't have the resources either. I'm interested from a NHS perspective that you're generating your evidence about implementation and how these products work in practice. But sometimes companies are going to, as you say, we know some companies come with more claims than with the evidence, but some are doing the evidence piece well. I'm just interested in what level of evidence you would like to see from some of these companies to be assured when you're using these products and services in your organization, because there's a danger we get into producing evidence twice. But if the companies are on this journey as well, there's a potential win-win. So I wondered if you had any final comments about that.
Yeah, I suppose there's evidence at two levels. So you want the evidence that what they've produced is something that ticks the boxes and that they've thought about the clinical safety. So therefore you think, you know, about your NHSX sort of DTAC, the digital technology assessment criteria. You want that evidence that what they've got is a product that has been thought through. Then you want the evidence that, I think too frequently we come across products where evidence has been generated that sounds great in the abstract. So we've got an AI algorithm that does the following and it's 90% efficient. Often what hasn't been generated is, well, what is the benefit from actually implementing this? You know, we understand that it can automate this part of the pathway, but that part of the pathway is one of 10 steps. And it doesn't make the step before or after any faster, so I've still got a bottleneck there. And so I think the kind of evidence that's helpful is the evidence based on real world deployments that's proven the benefit across different domains. So that's very clear. It's got a clinical benefit, which is this. It's got an efficiency benefit, which is this. Too often, I think the evidence is quite abstract and, you know, was probably often could have been found from a fairly researchy environment where, let's say, for an AI algorithm, the data was very clean, or it was based on, you know, a certain subset of machines gathering the data that don't represent what machines exist in the real world. So the kind of evidence I'd like to see more of is, I guess, actual evidence from real world deployments appropriately measured in order that they can inform this sort of benefits realization, this business case, so that we can actually not say we want to do this because it's really cool, but actually say we want to do this because if we implement it in this service, it will lead to the following benefits. You know, patient journey time will be reduced. We'll be able to reduce their appointments by 10%, something like that. And there's very little of that that I come across. A lot of the evidence looks really great, looks really convincing in a presentation, but is difficult to realize the benefits that they got from their research because the system you're implementing in is just too different, or it's just a real world system rather than an abstract one.
And it's certainly something our team have been thinking about and hearing again and again from different stakeholders is this is an evidence generation journey for digital health. So there may be very early research undertaken by companies for product design and development and perfecting the offer, but then that implementation piece, that real use in clinical settings and pathways within a particular health system is so important for making the business case for adoption. And if that's missing, it can be really a struggle for certain services to be adopted. So, and then as you say, that's not the end of the story either. It's that continuous monitoring and audit. So the organization has incoming information to go, this is scalable, or this is including or excluding certain people, and then you can optimize it. So, I mean, it really is a continuous evidence generation piece, isn't it? I think in digital health, that's what we seem to hear.
Absolutely, yeah.
But we will continue to watch this space and everything you're producing at Moorfields. And I think it's a really interesting example for other organisations who are embarking on this journey. So thank you very much. In terms of next steps, these webinars will, they go up on YouTube, so the content will be available. And I was just going to say a few final words. This is the final webinar in our series. This is the fourth one. This series has been supported by the organisations below from funding from UCL and King's College London, and delivered with amazing operational support from the Health Innovation Network and DigitalHealth.London. So it's been a delight to have you and all our guest speakers in this series. And there is a group of us behind the scenes who have been engaging with stakeholders, SMEs, and running an expert advisory group on this topic of evidence generation for digital health. And we will be writing a report with recommendations for the digital health landscape in the summer, and looking to launch that in the autumn. So again, please watch this space. Please follow DigitalHealth.London for more information about the work we've been doing. And last but not least, thank you, Paul, and thank you, Pete, particularly for your time today, and all of those who have joined.